It's really a pleasure to have Health Policy Grand Rounds today with Anya Rader Wallack. As you know, Anya is the chair of the Green Mountain Board. No small job. I think the governor of Vermont has taken on a tremendous challenge in a way that I think the country really needs to think about as well, and I hope it will be a model where we can actually bring all providers and payers and patients together as one to think about solutions for a system that really is broken, costs too much, and doesn't provide the kind of quality we'd always like. And yet we have leaders like Anya who are really dedicated to this, not just in this role as chair of the Green Mountain Board, but in her whole history, working with the Massachusetts Medicaid Policy Institute, working in Rhode Island, and previously working in the Clinton administration with our own Greg Myers at the same time. And I've gotten to know Anya a little bit better over the last couple of years and been privileged to be in that space, trying to take on something that's been passionate for Dartmouth for a long time through the Dartmouth Institute and my 16 years there, looking at healthcare, and to see a group finally come together and take these things on seriously is really just a true joy and a pleasure. Our natural partnership is around the same goals: improving health, improving quality, and trying to lower cost. No small challenges. I really am so happy that Anya took the time today to spend with us, and I look forward to listening to her. I will, as she knows, have to leave a little early for another engagement, but thank you so much for coming, Anya. It's great to have you.
Thank you. Thank you, Jim, and thank you all of you for coming this morning. I was here, I don't know how long ago that was. I came with the governor, maybe a year ago? Yeah. Something like that. I was in my previous position, which was staffing the governor on health reform, and so I sat in the crowd and, in case anyone asked him a really hard question. And today I'm going to talk probably in a little less inspirational terms, but hopefully a little bit more concrete about what's up with healthcare reform in Vermont, and try to give you a sense not just of what my board's role is, but some context for the overall plan and how we fit in. So I am chair of the Green Mountain Care Board. It's a 5-member board that was created under a law that passed in Vermont last year. It sort of set us on the road toward achieving some short-term and long-term health reform goals, which I'll talk about today, and is taking on one major, really major, component of our health reform plan, focused mostly on cost containment and population health improvement, which is stuff I know you guys hear about a lot, and Jim probably could describe this mission as well as I can. I do think we share a lot in terms of our goals, and I applaud you, Jim, for your leadership here. I go around the country and talk from time to time to folks from other states, and they think I'm from another planet. Like, you're doing what? And I have the feeling Jim may get some of that from his colleagues around the country as well. So we are doing things somewhat differently. I think we're doing things in a better, more thoughtful way. And if we're successful, we can create some sort of a model for the country. Won't fit everywhere, but certainly for small, rural, like-minded places, this could be a great model. So I look forward to working with this organization towards our goals. So as I said, the board was created last year under what we call Act 48. The way I think of that law is it had 3 major parts, each of them assigned to a different part of state government. The board was created to be somewhat independent. We were appointed by the governor, but once he appoints us, we don't serve at the pleasure of the governor. So that's intended to provide a little bit of distance from, frankly, the day-to-day political process and the workings of the executive branch. So we have broad decision-making authority, but we don't report directly to the governor. The other parts of the law, hopefully you can, this is good, you guys have a nice big screen. There's three major components, as I said. I'll talk in a lot of detail about our responsibilities, which are the 1/3 of the pie. The green part, the exchange, is the responsibility of the Department of Vermont Health Access. They used to be a division, so I always trip over that. DEVA, it's affectionately known as in Vermont. They are our Medicaid agency, and the exchange, for those of you who aren't familiar with that concept, is really a creature of the federal health reform law that passed a couple of years ago. The exchange is meant to essentially reorganize the healthcare marketplace in terms of insurance purchasing. So it doesn't get into healthcare delivery or cost containment, but reorganizes how people in certain portions of the insurance market purchase insurance, namely the small group market and the non-group market, so people who are purchasing on their own and not through an employer. And what it's meant to do is at its core, provide for a web-based experience. You can also still go to a regional office, social welfare office, and sign up for coverage. But most people are expected to sign up for coverage through this exchange if they work for employers who have 50 employees or less, or they're purchasing on their own. Starting in 2014, this will be where they go to purchase insurance. And the insurance will be much more standardized than what you see in today's market. So they'll get much more apples-to-apples comparison. And standardization of products across carriers. Now, one of the ways in which Vermont is different from many other states is we have a much simpler health insurance marketplace to begin with. We have 2 carriers in the small group and non-group markets. We have 1 more carrier in the large group market, Cigna. But it's already fairly simple. Nonetheless, you wouldn't believe, and I'll talk about this when I get into describing our role as the board in the insurance rate review process, you wouldn't believe how complicated they could make 2 carriers be in terms of the array of products, the nuances between different products, how those are rated, and so on and so forth. So the exchange is intended to really take the standardization and simplification to a new level. Vermont really went beyond what any other state had done in terms of the exchange, in the sense that we said, if you are purchasing in the small group market starting in 2014, you will purchase through this health insurance exchange. The thinking behind that was, it's a small state, we got 625,000 people. We've seen what fragmentation in our small group market can do in terms of creating confusion and rate differentials. If we're going to build this thing and sort of install the best technology around insurance purchasing, let's have the benefits of that accrue to everyone, and let's make sure that there isn't gaming of the market, which so often has happened when we've tried to reform the insurance market. So that's all about the exchange. The folks who are in charge of that are on a mission to start up the exchange in 2014. They actually have to be able to enroll people late next year for coverage. And there's a lot of work there to be done around information systems and creating this web portal and all this stuff that I'm glad is not my responsibility. The other thing that DEVA has responsibility for pre-existed Act 48, and that has to do with our what used to be called the medical home model. Now we call it the advanced primary care medical practice model. I think at least last week that was what we were calling it. It keeps morphing. This has been in place for a number of years in Vermont. It was an initiative actually of the Douglas administration to really redesign primary care practices around Vermont. And about somewhere between half and 2/3 of Vermonters currently are enrolled in what we call a blueprint practice, which is a practice that has met the NCQA accreditation standards for medical home designation. In Vermont, what we've done, in addition to having the practices meet those accreditation standards, we've added a community health team. Some of you in the room may be familiar with this, may even work in a blueprint practice. We've added a community health team which provides sort of adjunct support to the healthcare providers in the practice. particularly to hook patients up with either social services or additional services like a mental health practitioner who rotates through the practice on a regular basis, or dietitians. A lot of the practices have that as a support service as well. The reason there's that blue arrow is the blueprint has a direct connection to what my board is doing under payment reform, and I'll talk about that in a minute. So that whole rollout of this blueprint concept is continuing. More practices are coming online all the time, and we expect that by sometime in 2013, all Vermonters will have access to a blueprint practice. Participation is not mandatory. Healthcare providers, primary care providers, can decide to remain outside that model. But frankly, as the rollout has continued, so many of them are finding that it's a better system in which to practice, that we're getting more signing up than we can bring online as quickly as they would like to. So that's good news, and will be really fundamental to everything we build in terms of cost containment and delivery system reform in Vermont, I believe. So the third piece of Act 48 has to do with the whole single payer plan. And so a lot of times when I talk with folks about Vermont's health reform plan, this is the thing that takes precedence. People have heard the most about Vermont's plan to move to a single payer system. And they wonder if it's happened already. Is it going to happen tomorrow? What's the effect going to be on them? And this is actually the piece that is farthest out in the future. So I'll try to bring a little more clarity to that if that hasn't been clear to you all. What the legislature did was pass the broad outlines of a program called Green Mountain Care that would be available to all Vermonters by virtue of them being residents of the state, that would replace what is currently private financing to the extent that we can with public financing. I say to the extent that we can because there's a certain array of self-insured employers who, if they choose to remain outside the system, could do that. But to the greatest extent possible, replace private financing with public financing. Now, about 50% of healthcare financing in Vermont already is public, either Medicaid or Medicare or some other public source. So it's the idea of moving to public financing isn't as radical as it might sound on its face. But the legislature passed this broad outline, did not specify the financing mechanism, and did not specify some of the operational details, some of which are particularly important to folks who either work here and live in Vermont, or live in New Hampshire and work in Vermont and want to know, how is this going to affect my employer health benefits, folks who live in Vermont and get services here, which is, as you all know, a whole lot of people. How's it going to affect my access to services? So all of those details, the governor's office and the Secretary of Administration have the responsibility for bringing back answers to all those questions, and a full proposal for financing the single payer comes back to the legislature next January. To implement that would require a federal waiver, which under current federal law is not available until 2017. So it's the governor's intention to pass the bill and then go to the feds and ask for permission to implement what has been passed. There is legislation in Congress that would move that date up from 2017 to 2014. But not a whole lot of hope that that's going to pass. So at this point in time, that's the timeline on the single payer piece of the plan. So my board's role, as I said, has to do with cost containment and delivery system reform and population health, all rolled up in one. Our task, there's a long list of powers and duties we have under the law, but we boil our task down to making sure that the rate of growth in healthcare costs is affordable in Vermont, and that we are improving the health of the population. So if you think of it in terms of kind of your standard value equation, if value equals health over costs, we're actually right now in the middle of trying to figure out how will we calculate that? What metrics are we going to use to estimate the health of the population, track the health of the population and any improvements or degradation over time, and relate that to healthcare costs. What is healthcare costs, for example? Is it just healthcare services? Probably not. Probably goes beyond that, because we all know that as important as the work you all do is, it is not the be-all and end-all of health. So very similar to, I think, some of the things that I've seen from Jim. We're looking at kind of how do you figure out what the numerator and denominator are in that value equation. And our job is to increase the value. And we are focused on doing that at the direction of the legislature, in part through payment and delivery system reform. So they gave us a clear charge to move away from fee-for-service payment in Vermont to the greatest extent possible. I wouldn't say we're going to eliminate fee-for-service. I don't think that's realistic, but I do think that we can make major strides, appropriate strides, to move away from fee-for-service as the dominant form of payment. They also instructed us to be cognizant of and try to eliminate cost shifting between the public and private sectors. So again, a major challenge in our work is to figure out how to do that as we move toward payment reform. How do we reduce or eliminate cost shifting? How do we make sure that the public sector is paying its fair share when the public sector is obviously under a lot of financial stress? But the legislature recognized that having that kind of balance and fairness across payers was important, not just in terms of the concept of fairness, but probably equally important in terms of having some ability to make sure that costs aren't just getting shifted around, but actually are constrained overall. So as we look at payment reform, my board, have set up some goals. We have the responsibility for implementing payment reforms on a pilot basis, and we're currently engaged with providers around the state, mostly hospitals, but some physician groups as well, around implementing pilot programs. And I'll talk about the 3 basic models in a minute, but the goals of these pilots, which we will test over the next couple of years and try to scale up to the extent that they're successful, are to move away from fee-for-service, as I said, to build on the blueprint, so to have the blueprint, as I said, really be the foundation for where you go with payment reform. So not payment reform that's disconnected from primary care, but payment reform that somehow creates stronger linkages between primary care and specialty care and hospital care. So all of our pilots will be somehow connected with blueprint practices, and I'll give you some examples. Include all payers, public and private. So most of our conversations so far have been within the state with the private payers and Medicaid, trying to figure out the mechanics of these pilots. But we've had some discussions with CMS about involving Medicare as well. There's a Medicare demonstration initiative that's forthcoming called the State Initiative. And we intend to apply for that. It should give us greater flexibility than is allowed under the current demonstration authority to implement statewide payment reform that includes Medicare. We see that as critical, and I don't think I need to explain to you guys why. And we're also talking with Jim and with folks at Fletcher Allen about the ACO concept and what Dartmouth already has underway, what Fletcher Allen could get underway in the next round of ACO applications. And then lastly, incorporating performance measurement. Again, something I know Jim is near and dear to Jim's heart, but making sure that in moving away from fee-for-service, we put quality in the forefront and make sure that we are assuring consumers in particular that we will monitor the impact of cost control on quality and not repeat the mistakes of the past in terms of moving toward capitation and not having adequate means of judging what's happening under those kind of payment models. The 3 basic models that we've been pursuing, 2 of them are consistent with the federal models around bundled payments and around the accountable care organizations. And then the 3rd one in the middle is sort of unique to Vermont, but built off of some experience in Maryland. We have just received a grant from the Robert Wood Johnson Foundation that is supporting the state's efforts to develop these models. And we're in discussions with hospitals and other providers in Vermont about what kinds of investments might be necessary up front to make these pilots work, how to measure quality, what kind of trend line we can expect so that whatever investment we're making is shown to be a good investment and pays off over some multi-year period. and all those kinds of details we're currently working through. So the three basic models are bundled payments. You folks are probably familiar with this. You know, you take something like a total joint, and for a 60 or 90-day period around that procedure, bundle up the payment sort of into a super DRG that goes beyond the hospital and provides for some opportunities for savings and efficiency that goes beyond just the walls of the hospital. The second model is physician-hospital global budgets. We have had a hospital budgeting process in place in Vermont for a long time, since the early 80s. Hospitals annually go through a state review, and that has been more or less binding over the years. At this point, it is binding on them. We actually control the rate of increase in their net patient revenues from year to year. That has had some effect on moderating hospital cost growth in Vermont, but what we found is that hospitals still need to make that bottom line. They can stay within underneath the cap often, but they have to worry about, are they bringing in enough revenue to make the bottom line, and they have to worry about how profitable are services, and do they need to bring in some new service that's more profitable at the margin. The physician hospital budget has been used, actually in Maryland, it's just a hospital budget, and it's been used as a way of guaranteeing some base revenue to a hospital, so you sort of take away some of that volume incentive that they would otherwise have. In Vermont, we're calling it a physician hospital global budget because about 2/3 of the physicians in Vermont are actually employed by hospitals, and therefore those expenditures are within the hospital budget. But we think that particularly for smaller, more rural hospitals that have a real stable patient base and a stable payer mix, this is a good way of reducing that volume incentive, making sure that they have the resources they need to support what would be core community services, things that anyone would agree should be available in that community, and not having them worry about how to add something that generates more revenue. Then the last is global or population-based payments. That's just another way of saying ACOs. It's some form of a full payment for care for a population. Really, the only places in Vermont that are able to pursue this are Fletcher Allen and perhaps a couple other hospitals that have the volume of patients to make this possible. So we are in active discussions about how to implement that as well. What's been interesting to me, I have a background, as Jim made reference to, I think, I worked in the Vermont Program for Quality in Healthcare, which is a quality improvement organization. Some of you may be familiar with it in Vermont. As we've gotten into all of these projects and working through with providers how they will work, how we operationalize them, they all come back to being sort of classic quality improvement. It's all about, whether you're talking about a bundled payment with orthopedic surgeons, or I'll tell you in a minute about an oncology project that some folks here are involved in. The people who are trying to do those bundled payments are looking at their care process and trying to redesign it, make it as efficient as possible. And what we can now bring to bear that we didn't have in the kind of classic quality improvement is a new payment model that really supports that. And that's what we're looking at sort of across the board with these models, is first talk about what you're going to do in terms of care delivery and how you're going to either better manage an episode of care or better manage the total needs of a population. And then let's look at what's the financial model that maximizes our success in that. So what does this mean for Dartmouth-Hitchcock? Well, you have to be part of the Vermont system. Sometimes people are shocked to hear me say this, but I think 40% of your admissions come from Vermont. The idea that we would take access to this facility away from Vermonters is frankly kind of ludicrous. It just wouldn't work. It wouldn't serve Vermonters well. It wouldn't make sense. And this is a high-quality facility that Vermonters rely on, and so we need to make sure that Dartmouth-Hitchcock is part of whatever Vermont system, whether you're talking about in the short run, the kinds of redesigns that my board is working on, or in the long run, the kind of broader redesign and single payer system that the governor's folks are working on. Either way, Dartmouth-Hitchcock has to be part of it. Oftentimes, I equate this to what we currently do in our Medicaid program, which is probably not your best payer, but we do better than New Hampshire. But yeah, we set the bar high. But at any rate, Medicaid contracts with out-of-state providers, we have to make those kinds of arrangements. You happen to be a particularly significant out-of-state provider, but I think people often make too much of a big deal out of having to come over a bridge to get here. On the other hand, my board's job is really regulatory to a great degree. And we have certain regulatory processes that allow us to control healthcare costs through hospital budgets, through health insurer rate increases, through certificates of need. We don't have all of those regulatory authorities over this facility. So in discussing with Dartmouth-Hitchcock what your role will be in the Vermont system, we have to find ways to make sure that we have adequate assurances that you'll be sort of playing by the same rules as Vermont-based providers. But having said that, you have to be part of the system. And in fact, we need you to be leaders in the system. I think you're showing that you are. I think Jim is showing that he is a leader in this system already, and many of you are. We share the goals of lowering the cost trend and improving the health of the population. And I think whether it's in our payment reform efforts, through the kind of innovation that you guys are going to do under the grant that you received last Friday, which congratulations, by the way, to anyone who was involved in that, to your involvement in the Oncology Project, to which I made reference, that's in St. Johnsbury. I think there are some folks here who are involved in discussions around total joint care that will have some implications for Vermont hospitals. And I already talked about the ACO development. On all of those fronts, I think that either as a total system in the case of the ACO project, or in terms of clinical leadership in orthopedics or oncology, or in terms of providing some really out-of-the-box new ideas about reallocating resources and paying for a different kind of healthcare workforce, as you've proposed in the innovation grant. These are things that you can provide to your broad marketplace and to Vermont specifically that will be of real benefit to us. I just want to say a little bit about the Oncology Project because it is kind of cool. And we expect that the board will approve a pilot around that very soon. So this is the blueprint practices in the Northeast Kingdom of Vermont around St. Johnsbury, the Northeast Vermont Hospital, NVRH, and the Norris Cotton Cancer Center, which you guys have probably heard of. Clinicians from all three of those organizations working together to redesign cancer care, and all of the payers in Vermont agreeing that they will pay for care management for cancer patients that is done by those practitioners, not care management that comes in from an insurer or some other place, but care management, a care plan that is managed by the primary care provider and the oncologist. In the case of this model, what we're proposing is that the payers simply pay for that care management plan and that the providers develop protocols around that for things like imaging to avoid duplication. But our focus is really on quality improvement. I think there are good examples around the country of why we might assume that this will reduce costs, but our focus in the project has really been on quality improvement and how we can make the experience of care less frustrating and better quality for patients and have just better communication between the providers. And we think that that will be a real successful model that, if it was rolled out to the entire state, would have major implications in terms of cost and quality of oncology care. So thank you if any of you in the room are involved in that project. I think it'll be a really neat one. I'm going to go back to the first slide just to try to make you dizzy again, and just recap by making sure I tried to focus on the payment and delivery stuff here, but I want to make sure I've made clear that we have these other responsibilities before I wrap up. So payment reform pilots I talked about in a lot of detail. Our role there is to launch the pilots, operationalize them, and then try to scale them up over a short period of time. We're responsible for this hospital budget review process now. Hospitals will be coming in with their budgets for the next fiscal year in July. Their fiscal year starts in October. So we're engaged in discussions with them about how they can live under a rate of increase of 3.75% in their net patient revenues, which is the target that we've set for all the hospitals in Vermont for the coming year. That rate of increase has been coming down gradually over the years. The legislature actually had imposed the caps for several years running, and then we, in discussions with the hospitals, arrived at 3.75 for the coming year. And then we're responsible, we have partial responsibility for insurer rate reviews, and this is where I'm learning about the unbelievable complexity of a simple health insurance marketplace. So we've just got 2 carriers. We only have purview as regulators over small group and non-group, but hundreds of filings come in every year. They have been reviewed in the past by what was called the Department of Banking and Insurance Securities and Healthcare Administration, has just changed its name to the Department of Financial Regulation. They review the rates to make sure that they'll support the solvency of the insurer, and that they're not unreasonable in terms of the contribution to the bottom line of the company. We now are a second step in that process. The department reviews the rates and then makes a recommendation to us, which we can accept, reject, or modify. So we're kind of learning our role in that and trying to make sure that we're not just another level of bureaucracy, but that we bring some value to, some added value to the process. We're supposed to take into account things like the effect of what insurers are doing on quality of care, the affordability of the rates of increase that are proposed relative to how our state income or our means of paying for it are increasing. So sort of all the principles that were enveloped in last year's law, we are now supposed to bring to this process. We will be recommending modifications, I think, over time to make the process more simple and transparent, because frankly right now you look at one rate increase for a very small chunk of the market and it's totally disconnected from the overall impact on costs or quality, and we need to do a better job of making that coherent. We begin reviewing certificates of need next January, but thank goodness we get a little bit of a reprieve on that one. And then we have broader responsibilities that we could use, like all-payer rate setting. Obviously not with Medicare, they get to do their own thing. But we have the authority to standardize provider rates across all payers, and various and sundry other responsibilities. But these are our core focus right now. And what we're really trying to do is sort of make them all connect and, as I said, be coherent, so that when we're making a decision about an insurance rate review or a hospital budget or a payment reform pilot, they're all sort of grounded in the same policy objectives, and we can see in a much more transparent way how they impact, how the increase in the hospital budget affects the insurer rate increase, how decisions about the state Medicaid budget affect private health insurance rates, for example. So that's the big idea, and it's a lot to do, but at least I don't have to do everything. Like I said, a lot of times people think I have to do all of this, but we've got plenty just on our plate, and I'd be happy to take questions about any of this. Yes, Greg.
So I think as we hear about those 4 big aims about moving away from fee-for-service, about trying to build a primary care model, the work that's being done on trying to include all payers, that's work that you can do better from government than we can do better from where we sit, and then trying to lead with quality, with the performance measurement piece. The alignment's terrific, but I think what most folks here in the back of their head are saying, this is great. Yeah, there's a lot of consistency here. Many of your slides could have been slides that Jim or others present to this audience, but it begs the question of, well, what can we do together now? What's the next step for Dartmouth-Hitchcock as we think how we want to work with Vermont in this development? Because it's not a case of having to realign ourselves. Right. The alignment's terrific, but the next steps aren't clear.
Right. Like I said, I think a lot of it has to do with providing leadership on these fronts. the sub-bullets. So being, as you have been over the last months and years, leaders in terms of helping us, partnering with Vermont providers, or on your own, developing models that encompass those goals. Now, I think what a lot of the Vermont providers have that you don't have as much of over here is a Vermont primary care base. So I'd say one thing you can really do is strengthen your connection, as is happening through this Oncology Project, you strengthen your connection with that Vermont primary care base. And I know through discussions with Jim that that's something he's talked about. But I think, taking on that role of being something more than an academic medical center, something more than a tertiary care center, and really a broader role in the community, and then providing models for doing that that don't threaten people because they think, oh, you're just trying to take over the world, but actually provide some leadership. I think that's what you can do. And then, you will, as you are now, because people want to come here and essentially demand access to the system, I think you can have an even stronger relationship with Vermont.
Just a follow up to that, Anya, and Jim had actually wanted to ask this. The grant you referred to, I'm not sure everybody's heard about that yet, but that's a $30 million grant. No, it's fine. It's a $30 million grant for the High Value Healthcare Collaborative where Jim's leading.
15 systems, I think.
16 systems and 50 million people. And so, specifically with that good news, how can we use the High Value Healthcare Collaborative to help in the Vermont effort?
I can't answer you precisely yet because I haven't read through all the details. But I think, again, to the extent that provides a care delivery model that is successful, more efficient, improves patient experience. That's one of the things I really like about that whole model is it's sort of, it's using non-clinicians to really create a better connection to the patient, which I think is a terrible missing link in a lot of what we do. I think that could be a model that would be transferable across the border, and we'll just have to see how it develops. And I don't know if there are ways in which you can work with Vermont providers from the get-go on making sure there are Vermont sites for that, but I think it's a great idea.
So thank you.
You're welcome.
This is really helpful in thinking about the whole picture. So as we are eagerly awaiting the Supreme Court's decision at the federal level, can you comment on how durable you believe this program and thinking is in the Vermont system?
So the Supreme Court decision is imminent, and my opinion on its potential impact on Vermont depends really on the scope of what they decide. So if what they decide is simply to strike down the individual mandate, which is the most controversial part of the law, and sort of most predicted to be struck down. I don't think that the impact on Vermont is particularly significant for a couple of reasons. One, we have an explicit health policy goal in Vermont to cover everyone, which is very different from other states. So we're trying to find ways to pick up those increments of people who remain uninsured, and even those who are underinsured and have a lot of financial exposure. We have done a lot in Vermont to cover people through various expansions of our Medicaid program, under our Medicaid waiver. And I think there's a whole lot that we can do to just maximize coverage through Medicaid. And about half of the Vermonters who are uninsured are estimated to be eligible for Medicaid now, but not enrolled. And a lot of the reasons that they're not enrolled don't have to do with the fact that they don't want health insurance. It's that they fall off of coverage due to paperwork that's not returned or changes in their circumstances. And I think you could do a lot to pick those folks up and retain them. One of the ideas, the reason I went back to this slide, one of the ideas of the exchange is to sort of minimize gaps between different types of coverage so that we lose fewer people. And it's amazing the extent to which, if you look at transitions in public and private insurance, what the wonks call churning, where people fall out of coverage, is really a significant factor in terms of people not having insurance, and where they tend to, you probably know this, where they tend to pick it back up is when they come to the healthcare provider, and the healthcare provider re-enrolls them in coverage. So because we are trying to cover everybody, and I think we can do a lot where other states sort of avoid, like, don't look, don't tell, and we won't have to pay for their coverage. Vermont sort of is trying to go in the other direction. Also, we've had insurance reform in place in Vermont for about 20 years, and the reason the mandate is in the federal law is that the national insurance industry said, if you're going to require us to take all comers, you better make sure that some good risk comes with the bad risk. And we've really had that market shakeout in Vermont a long time ago, so that the insurers in Vermont are used to taking all comers. There's much more even rates across all people. And then we have a fairly low rate of uninsured now relative to other states, again, because of what we've done to increase coverage through our Medicaid program, because our employers tend to, like Massachusetts, cover employees more than a lot of other states. So that the increment of people who could remain outside the system if we didn't have a mandate would be, I think, relatively small and not significantly undermine what we're trying to do. We also could do a state mandate, a state-level mandate like Massachusetts did if we chose to. If they strike down the whole law, there are two things that become significant. More significant in my mind. One is there's a whole lot of money that comes into the exchange, and I should have mentioned this before, in 2014, new federal tax credits for people to purchase insurance and have it be more affordable. We lose that money if the whole law goes down, and that could be significant in terms of our efforts to cover everyone. And then probably the least likely part of the law to go down, but still somewhat imperiled, is the Center for Medicare and Medicaid Innovation. A lot of what we're trying to do around payment reform, and including Medicare and payment reform, was authorized under the ACA through this new Center for Medicare and Medicaid Innovation. And if that demonstration authority was to go away, it would not eliminate the option of doing that sort of stuff, but make it more restrictive. CMS would have to operate under pre-existing authority that was fairly limited in terms of scope and time limited.
Yeah. If you could please introduce yourself too, that'd be great.
Hi, I'm Bob McConnell. My question is how does your work on health reform intersect with making more robust the public health system, given potential investments in public health may have a greater impact on health?
So I'll talk about it at two levels, conceptually and then operationally. So conceptually, I talked about that value equation and thinking about what is health. As we're getting into trying to quantify that and gauge our impact on health with the various interventions we're looking at, we're getting beyond thinking about just straight healthcare services. And so looking at spending and return on investment in public health, as well as spending and return on investment in healthcare services. So that's sort of in our conceptual thinking. I'd say operationally, at this point in time, there's very little connection. Public health is the purview of the health department in Vermont and has not traditionally been married with the healthcare services system particularly tightly. So we're looking at ways of improving that, and I think time will tell whether we're successful. We don't in Vermont have the county government structure that in some states makes that system a little more robust, I think. But even in those states, I think there tends to be a real split between these guys do public health, we do healthcare services when people are sick or need ongoing care. And so we'll have to find ways over time to create better integration, and I welcome any ideas anybody has for how to do that. I mean, one way, I think that is one of the benefits of the ACO model, actually, is that it will cause healthcare systems to start to think about this whole realm of how do we prevent illness and improve health that we really haven't thought about in the past, because that hasn't been our responsibility. So that is a concrete example, but still that's sort of the healthcare system doing it, not married with the traditional approaches. I'd call on you, but Greg is in charge.
I'm Bob Harris, and I'm a working physician here. I don't see too many other physicians I know here.
They're working.
Yeah, I was on call this past weekend, and the question I have for you, are there provisions in this plan say we had a recent Bikers Week in Laconia, which generates lots of trauma, which we get here, consumes lots of resources. These people may be from out of state, may not be insured. I mean, how are you going to handle that when an incident, say a big bus accident happens on 89, 50 foliage tourists are seriously injured, they go to Fletcher Island, they go to central Vermont. How do you handle that influx of resources consumed without necessarily payments?
Right. So the answer is we handle it case by case. I mean, basically, we have this hospital review process where we set a budget for the hospital. They propose a budget. We set a rate of increase. They live within that rate of increase. But there are all sorts of unforeseen circumstances that affect how that actually, what their actual is at the end of the year. And I think we've developed a pretty good process with the hospitals over the years of understanding when there are things. For example, this year, our state hospital closed, our state mental hospital, has had an impact on several hospitals in the state in terms of having to have additional capacity to accommodate patients who normally they would have gotten rid of fairly quickly and sent them to the state hospital, in terms of having to have sheriffs or other kind of protection around for patients who are there longer than they would have been and might be a danger to other patients. So we are cognizant of that and asking hospitals to let us know when that is affecting their budget. I think any system would have to take that into account. In terms of the not being paid for, if it's out-of-staters and it's not paid for, that's going to be bad debt no matter what. In terms of in-staters who aren't paid for, we tend to have a much lower degree of that in Vermont because so many more people are covered through public programs. So our bad debt and free care is pretty low relative to other states. But nonetheless, there's some in there. Hospitals kind of roll along at the same level every year, so there may be some big blowout one year, but in general, they kind of keep the same amount year to year.
Near Steeple Block, I've been fortunate to be in some of the discussions with Fletcher Allen and your staff about how we can work together to do this. I wanted to ask a question about one of the goals of eliminating the cost shift. And I think in part of the Vermont legislation, not only was it payment reform, but it also recognized that a goal was to keep the viability of the healthcare system intact, too, so not for all the hospitals to go out of business trying to achieve this. If the cost shift goes away, that either means that the cost of the private payers, the payments we receive from them come down to Medicaid levels, or Medicaid comes up, maybe somewhere in between. And there's going to be probably a shift around there of the government's responsibility versus the private sectors. And how has Vermont thought about its budget going forward, and whether this is going to be more cost on the part of the state, and how it would fund that going forward?
So first of all, I'd say it's somewhere in between. Everybody coming down to Medicaid would not be a viable option. On the other hand, there is some built-in commercial rate load as a result of cost shift from the public sector. And so to the extent that Medicaid comes up, the commercial payers could either expect that payments would come down or that the rate of increase at least would be lower over time. So you get into thinking about this on a statewide basis and it gets wicked complicated real fast because you have not only differences in payment rates in sort of cost allocation across institutions, but also differences in payer mix. And when you try to think about a way of reconciling all that and making it sort of all even, it's mind-boggling. So the sort of dipping our toe into that water that we've done so far is around these payment reform pilots. So if you take one like a population-based payment, we're talking with Medicaid about how could you come into a population-based payment model where you had some base and a reasonable rate of growth. And one of our biggest challenges in that has been getting data to look back at what that base has been historically for Medicaid and how it compares to commercial payer per person payments, how you adjust those so that you're doing an apples to apples comparison, and then go to the budgeteers and make a case that, you know, you really have been getting, even though you guys know, on a fee-by-fee basis, they've been getting a deep discount. We're trying to look at it in a more holistic way and make the case that you should bump your payments up while coming into this model that will guarantee you a lower rate of growth over time. So we are building that case and talking with folks in Medicaid and within the administration about these models and what their role would be and what the fiscal implications would be. I'd say the data challenge I've hit on. We have a data set now that includes all commercial claims and Medicaid claims for 2007 through 11, but just are starting to get to the point where we can make even the most rudimentary comparisons. So the data has been a challenge. And the other challenge is, you know, everybody sort of conceptually gets this, and then you go talk to the chief budget officer of the state, and he says, oh, but I don't have any money. You know, so it's going to be tough, and we're going to have to convince folks on a case-by-case basis that this makes more sense, because if you look at what you've been spending and how it's been trending over time, the only way you're going to get a grip on that trend is to make fair payments with a guaranteed lower rate of growth and pay your fair share and get better healthcare management out of it. And that's the part that I think Medicaid in particular can really benefit from.
We have time for one final question.
I'm Robin Mackey, Chief Financial Officer. Just a question, as you think about what's happening in all three of these slices, what are the one or two things that keep you up at night? Or what has changed now that you've been in the space? What you thought was coming in versus where you are right now?
So two things I think, broadly speaking, keep me up at night. Actually, there's, you know, dozens. but yeah, one or two. One is HIT. You know, I think that continues to scare me, the lack of connectivity across healthcare providers and healthcare systems. We're seeing that in terms of Vermont's effort to develop the Health Information Exchange, and in terms of the Blueprint's effort to develop a connection across all the Blueprint practices. And it just seems to be continue to be really challenging to create the kind of connections that I think will be necessary for better patient management. So that's one. The other is that whether you're talking, getting back to Steve's question, whether you're talking about budgeteers within state government or CFOs like you, it's really hard to sort of flip the system, flip a switch, change the economic model, and you kind of have to take a bit of a leap at some point. It requires the kind of leadership that Jim provides, but it also, you know, must keep people like you up at night. You know, like, oh, okay, this all sounds really good, but somebody's got to pay the bills. And when you kind of cross over that threshold, and how you make sure that there's adequate assurances that we're not going to go broke, we the state, not state government, but all the people of the state, and you're still going to have the resources to keep your institution humming efficiently. That's a tough challenge, and you kind of get people, you know, one step forward, two steps back, two steps forward, one step back. So just that sort of issue of timing and changing the financial model is a tough one.
So one thing I would say in closing, and I think that was a great last question, is that there's a lot for us to all be sleepless about together. With that said,
and then we'll all be really productive.
What I do want to do is I want to remind folks here about what a privileged place you're in. And both Anya and I have had the experience of working not too far south from here, where there is a real battle between the interests of academic medicine and large hospitals and small hospitals, and the direction that the governor is trying to go in the Commonwealth of Massachusetts. It's a pretty uncomfortable conflict at times, and we both, I think, have some scars to show for it. When you look at a slide like Anya showed about what Vermont is trying to do, and you recognize that that is virtually interchangeable with the kind of slides that we show on what Dartmouth-Hitchcock is trying to do, there's an opportunity here. So Thank you, Anya, for sharing that with us, and good luck with your work, and let us know how we can help.
Thank you.